I'm Dr. Karen Boretsky. I'm a pediatric anesthesiologist at the Boston Children's Hospital, and today I've been invited to talk about everyday point-of-care ultrasound for use in the ambulatory outpatient setting. And I first want to point out that I have no disclosures other than I really enjoy talking about this topic because I feel the point-of-care ultrasound has the potential to really improve patient care in our hands. My goals at the end of this lecture is I do hope that the participants are able to identify Pocus applications that might be beneficial to use in the ambulatory setting. And I want people to be able to apply these to improve patient care by providing more diagnostic options in critical situations. So the first thing is I want to just briefly go over what is point-of-care ultrasound, just to make sure everybody's up to speed and understands, what it is that we're talking about. And point-of-care ultrasound, otherwise called Pocus, is diagnostic or procedural ultrasound, and this is performed by the clinician at the point of care. So it's the anesthesiologist, it's the intensivist, it's the emergency medicine doctor. It's not the radiologist doing a comprehensive examination. And the reason we do this is because we have some questions we need to answer, and the point of care ultrasound gives us quick information to be able to guide our evaluation and management of the patient. It is accessory to the physical examination. Some of the current examples that are very familiar to people are using ultrasound for nerve blocks and vascular access. These are procedural ultrasounds, and what I'm really going to focus more on today is diagnostic ultrasound. And I want to talk about cardiac, pulmonary, and gastric ultrasound. So we'll start with cardiac. And with cardiac, you use the ultrasound to get images of the actual live beating heart. And here we have a parasternal long axis showing the chambers. This is the parasternal short axis showing the predominant left ventricle and the right ventricle. And the information that you get from this, let me just go back one. The information that you get from this is that you get the size of the heart relative the RV to LV size discrepancy. You can find out if there is fluid around the heart. You get a sense of how well the heart's contracting, and you get a sense of the filling volume. And so these are the only four things that we really are looking for when we're doing point of care ultrasound. It's not comprehensive. When we look at lung ultrasound, again, just a quick review. Sorry to bore those of you who already know this. When we look at the lungs, what we can see on the lungs is we can see the pleura moving between the ribs, and underneath the pleura you get some sense of the health of the lung below. And so right here we can see that the pleura is moving. It's the bugs on the log, the little shimmering line, and you know that the pleura is moving, the patient's being ventilated. The last of the three major Pocus applications I'm going to talk about is going to be gastric ultrasound. And we can use gastric ultrasound using a sagittally midline placed transducer over the gastric outlet. And an assessment can be made about the volume of the gastric antrum to determine whether or not the patient has eaten recently or whether there's a risk of aspiration with a full stomach. So what are the benefits? Why should you bother to pay attention? We can expedite the time to diagnosis in cases where there remains a bit of uncertainty, and we can minimize the delay to the provision of definitive therapy. So we're going to talk about some of these applications so you get a sense of what I mean by this. And so a lot of times when I'm practicing anesthesia and something unpredictable happens, something that I didn't really expect to happen, sometimes I feel like the guy on the right, like I have a blindfold on. I said, like, what am I not seeing? And what information am I missing to move forward in providing good care to the patient under my care? And this is a case report describing the use of point-of-care cardiac ultrasound to guide successful CPR after an unanticipated arrest in the ambulatory surgery center. And I just hate when I'm in the ambulatory surgery center and, things start to go wrong. Anesthesia-related cardiac arrest, 2 per 20,000 anesthetics, immediate survival rate of only about 50%. More favorable in the ambulatory setting. But let's talk about some ambulatory patients, lest you think that this might not apply to you. Here's a 41-year-old presenting as an outpatient for a partial vitrectomy, type 2 diabetes, hypertension, some chronic kidney disease. Patient is complaining of nausea on the morning of surgery. The anesthesiologist decides to do a rapid sequence induction using propofol and succinylcholine to secure the airway. And 7 minutes later, the electrocardiogram changes from ventricular tachycardia, from a normal sinus rhythm to ventricular tachycardia to ventricular fibrillation. So, what's going on and what information can we get by looking at the heart? And so the patient at hand is on the left-hand side. This is ventricular fibrillation. And so you can see the valves fluttering, the sort of uncoordinated myocardial contractility, as opposed to asystole, which is on the right. And there is no heart movement, no myocardial movement at all. And what we can exclude from the picture on the left is we know that the patient doesn't have a pericardial tamponade physiology and no effusion. We can see that the ventricles are full, and we can rule out severe hypovolemia. We see that there's no regional myocardial dysfunction, there's total myocardial dysfunction. We can rule out anaphylaxis in this setting, and the size of the right ventricle at the top. The right ventricle is normal sized relative to the left ventricle, and so we can rule out a pulmonary embolus. So there's not that in this case that we got the diagnosis right away, but we eliminated a lot of the immediately reversible causes of cardiac arrest. And it turns out the patient had hyperkalemia from his renal disease and from the succinylcholine. We did a report. This is a 15-month young toddler coming in for open reduction internal fixation of hip dysplasia. So this patient was categorized as an ASA 1 patient. And after the induction of anesthesia, while the surgeon was prepping, the patient developed hypotension, bradycardia, hypocarbia, all factors indicating imminent or actual cardiac arrest in this patient. And CPR was started, epinephrine was given, and we had an echo, we had a TTE, transthoracic echocardiography capability, put the transducer on the chest, and this is what we saw. And for those of you that don't understand what you're looking at, on the left side, I'm trying to get a little cursor up here. On the left side, this is the right ventricle, and it's filled with air, and the left ventricle is contracting like crazy, like someone just gave it some epinephrine, and it's completely empty. And so what had happened was the rotating resident had started a second IV and had forgotten to flush the air out. And this 7 kilo, this was a small child, 7 kilos, 11 kilos, developed a hemodynamically significant air embolus. And we immediately put the child head down, gave a large bolus of non-air containing fluid, resuscitated the child, and were able to, in fact, continue with the surgery. Finished it, explained to the parents what happened, and we're just happy to have been able to make that diagnosis. This next child is a 7-year-old ASA1 presenting for strabismus surgery. And after the induction of anesthesia, the patient developed atrial bigeminy. And the cardiac arrhythmias are very unusual in the absence of congenital heart disease in pediatric patients. So we tried to let it resolve. We waited 5 minutes, normalized the CO2, decreased the sevoflurane, and the arrhythmia persisted. So I ran and got my friend Al, who's a pediatric cardiologist, anesthesiologist, and I asked him, I said, what do you think? Should I proceed? What should I do? It's a healthy kid, the hemodynamics, everything's stable, but I have this atrial arrhythmia. He said, well, you really might need to worry about whether or not this child has had some kind of occult viral myocarditis. So we put the transducer on, did a TTE, and the left side is the parasternal short axis, and the right-sided picture is the apical four-chamber view. And what you're looking at here is a very, very dilated right ventricle that is in fact impinging on the left ventricle, which is smaller. And you see this D sign. And this is indicative of pulmonary hypertension. And you see it, you confirm that in the other view, in the parasternal four-chamber, you can see again, a dilated right ventricle, and the interventricular septum is impinging over onto the left ventricle. And this case, we got out of Dodge. We canceled the surgery, took the kid to the recovery room, proceeded to order a formalized comprehensive cardiac echo, and it was determined that the child had undiagnosed pulmonary hypertension and secondary to arterial pulmonary artery stenosis. And the child went for additional therapies, and we really feel that we prevented this kid from not only dropping dead on our OR table, but from dropping dead on a playground somewhere unexpectedly. And when we reviewed our literature at the Boston Children's Hospital, we found that of the cases where we used point-of-care cardiac ultrasound to look at the patients and where it changed care, we found that 4 out of 7 of those patients were in fact ASA 1 or 2 patients who could easily have been or were in our surgery center. One of the more common causes of cardiac arrests that we have in our surgery center is anaphylaxis. And anaphylaxis has characteristic signs of sort of distributive shock. I couldn't find any good pictures. The only thing I could find was this picture of this 18-month Yorkshire Terrier who presented with anaphylaxis. And I was intrigued that the distributive shock in animals, this isn't mentioned in people, but presents as fluid extravasation around the gallbladder. This is a picture of the gallbladder showing a halo sign. So I just wanted to point out that if you ever are faced with a 18-month Yorkie having anaphylactic shock, or you want to rule it in or out, if you look at the gallbladder, this halo sign may give you some additional information. I'm going to talk about pulmonary ultrasound, lung ultrasound, and in the surgery center, we frequently do procedures where pneumothorax is one of the known risks. So at the bottom left, we have a patient having a supraclavicular nerve block. In the middle, we have a patient status post central line, and upper right-hand corner is cosmetic breast surgery. And any of these would be typical cases at the surgery center. And in the event that we need to rule in or rule out a pneumothorax, this is well documented in mostly, again, the emergency medicine literature and the critical care literature, but the use of sonography to diagnose pneumothorax And the average time to perform a quick lung exam to rule in or rule out pneumothorax is less than a minute to rule out a pneumothorax, and just several minutes to rule one in. And on this slide, I'm just demonstrating the transducer in an apical position over the lung. And right here, the moving line is the pleura. So it's obvious in this patient that there is no pneumothorax, and if there is hemodynamic compromise, that something else would be implicated. There are some oddball things that you might want to delve into if you get really excited about point of care. There has been abdominal compartment syndrome diagnosed during hip surgery with fluid extravasation. Here was a 45-year-old asthmatic. As the incisions were being closed from the hip arthroscopy, the patient became hypotensive, unresponsive, apneic, intubated, and manual ventilation was difficult. The drapes were removed, revealing abdominal distension. And this is an easy diagnosis with ultrasound, because on abdominal ultrasound, free fluid in the abdomen can be seen around the kidney in Morrison's pouch. Another use of, after hip arthroscopy, of using intra-abdominal ultrasound is patients who have a lot of fluid extravasation or at higher risk for increased postoperative pain. And this can be determined using the point of care ultrasound and quantifying the amount of fluid that is present. So the last part of my talk, and the bulk of it, I'm going to reserve to speaking about gastric ultrasound, which I think in the ambulatory surgery center really is going to be one of the most useful applications we have for the ultrasound. And so we all know those sneaky snackers that come in. The kid who, mom lost sight of the kid for a few minutes, and maybe he had a little stash of Cheerios underneath the sofa. Mom found some crumbs on his lips, or, that older 76-year-old coming in for some surgery who, she always has breakfast when she takes her medications, and she remembers taking her medications, and she can't really remember if she had breakfast. And, so you're caught in this position where you're not sure whether the NPO status is really confirmable. And this was right. I had to alter the talk to include this picture. I had a teenager on Wednesday who came in appropriately NPO, was very anxious, having some cosmetic surgery, and due to the anxiety, we just threw an OG down and pulled up 300 cc's of gastric fluid. She was fortunately already intubated at this time, and we had not chosen to use an LMA. But had we chosen to use an LMA, this patient would have been at risk for aspiration and regurgitation. Ultrasonography is emerging as one of the true ways to be able to quantify gastric content, volume, and risk of aspiration. And for those of you who are interested in this, there are many, many articles out there, and this is the best review article. Anahi Perlis did the original pioneering work in this. She's an anesthesiologist up in Canada, and she's wonderful. And this really goes over all the science and the technique behind doing gastric ultrasound, which I really can't, I don't have time for today. These are examples of very small stomachs. These are patients who have truly been nil paras for the prescribed amount of time. And here's a sliver-shaped stomach here with nothing in it. And the same thing over here. You can see this thick muscularis around the empty lumen. This was a patient, this was one of our sneaky snackers. This was a patient who had snuck off, and mom found an empty soup can around, and we looked at the child's stomach, and it turned out that this is what chicken noodle soup looks like in a child who was hungry the morning of surgery. This was not a kid who was NPO. This was one of my research assistants. She had just eaten a salad, and I wanted to just show the difference between here with the soup. Let's go back to the soup. You can see all the edges of the stomach. There's no air inside. There's some noodles floating around, but it's predominantly has the appearance of fluid. When patients have chewed and masticated and trained some air into the stomach, you get this ground glass appearance, and you lose the posterior border. So we can tell what kind of food people have had based on the images that we obtain. The last 9 or 10 minutes, I want to talk about using gastric ultrasound to revise some of our NPO guidelines. And this is very exciting and more of a research application, but this is really going to change the way we handle NPO status in the operating rooms. So in the past, the NPO guidelines, for both breastfed and formula-fed infants, for example, from the intake of infant formula at least 6 hours before elective surgical procedures requiring general anesthesia, regional anesthesia, and sedation analgesics. So we prescribe this 6 months delay or NPO period for infants who are on formula. And this fasting guideline, which we adhere to so religiously, is based on very loose, controversial evidence. It's considered category 3. Category 3 evidence for this fasting guideline is stated to be equivocal literature from observational studies reporting inconsistent findings or do not permit inference regarding benefit or harm. Category D is even worse. It's just insufficient evidence with regards to risk of pulmonary aspiration. So we came up with these guidelines, and they worked for us for a long time. The incidence of aspiration is low, but can we do better? Are these appropriate? And we know that fasting time that in infants is longer than their usual feeding interval. Infants feed every 2.5 to 3 hours, so 4 to 6 hours is beyond what they're used to. 28% of our fasted children who were less than 47 months of age and on the smaller size, less than 15 kilos, become hypoglycemic, and some of these kids profoundly so. And for many of our children and your adults, the 2-hour clears fasting policy translates into 6 to 7 hours of actual fasting time, and sometimes up to 15 hours in some studies. And so overall, we know that fasting increases thirst and irritability in both children and adults, and more importantly, results in detrimental physiologic and metabolic effects, such as ketone bodies, hypovolemia with decreased mean arterial pressure. And at least in the pediatric literature, we find that optimizing our preoperative fasting times to shorter durations, we can decrease ketone bodies. We can have better stability of our mean arterial blood pressure, which means we really need to take a good look at our NPO guidelines to optimize this occurrence. And so in anesthesiology, just last year, 2021, was this article, which used ultrasound to evaluate gastric emptying time in healthy term neonates after formula feeding. And what they found was they looked at, they fed them, they got baseline scores, fed the babies. And what they found was that these term neonates, whether it was formula or breast milk, that their stomachs were empty at 150 minutes. So in just a little over 2 hours, at around the 2.5 hour mark, these stomachs were sufficiently empty that we could proceed with anesthesia safely. And this may revolutionize or change the way that we can allow patients to eat ahead of time. Lest we forget about our preterms, is that a different species? The same thing in preterm infants, we find that gastric emptying time is much shorter than our NPO times. And I really wanted to just show this cute little milk tummy. This is what a little milk-filled tummy on a preterm infant would look like on ultrasound. And that's full. You can see the fluid inside. And these are box plots looking at those preterm infants. And there was no difference whether they were milk fed, breast milk fed, or formula fed. And time equals 0 is right here. And within 3 to 4 hours, the patients had returned down to their baseline resting status of empty stomachs, and no difference between breast milk and formula. So this is going to make it much easier for those babies on breast milk to be able to be NPO for longer amounts of time. So in summary, I've gone through a lot of things very quickly. I hope that I have shown you that the point of care ultrasound is a powerful emerging tool that every anesthesiologist can learn to use to improve some of the diagnostic decision making that we're confronted with in the operating rooms every day, including in the ambulatory surgery center. And with that, I will conclude my talk. Thank you for listening, and thank you to the panel, panel that put all this together, for inviting me to share this with you.